What if the life you've been dreaming of isn't as far away as you think? Welcome to the Transforming Lives Panel podcast, where real stories meet radical change. With hosts Sharmin Prince and Mitzi DeDown.
Together, they bringing you unfiltered conversations with trailblazers, experts, and everyday people who've turned their struggles into strength. No fluff, just the tools and mindset shifts you need to rewrite your story.
Whether you're stuck in your career, relationships, or personal growth, consider this your wake-up call. Press play on transformation. Come on, dive in.
Welcome to the Transforming Lives Panel podcast. I'm one of your hosts, Sharmin Prince.
Mitzi DeDown.
And together we are here with Dr. Jim Jackson. But before we continue, just join us in a short breathing exercise so that we can be grounded and centered by taking a deep breath in through your nose and out through your mouth. Another deep inhale and exhale. Inhale and exhale and let go of everything that didn't serve you today. Take another deep inhale. Let go of the to-do list that you have. Another deep inhale and exhale. Again, in and out. And just be present with us as we continue for the next 35 or 45 minutes. And thank you for joining us in that grounding exercise. And our guest, as I said earlier, is Dr. Jim Jackson. He's a psychologist and a professor and PTSD expert at Vanderbilt Medical Center, where he directs behavioral health at the ICU Recovery Center. With 25 years of research on severe illness and trauma, he's the author of Clearing the Fog for Long COVID and the upcoming Reclaiming Your Life After Medical Trauma. His work has been featured in the New York Times, CNN, and The Atlantic. Join me in welcoming Dr. Jim Jackson.
Great to be with you all today. Really happy to be with you all.
Thank you. Is there anything that I missed from your bio?
I think the bio was just fine. You add things, your resume gets really long and you don't even remember. I don't even remember what it's comprised of. So you did just fine, just fine.
Thank you. Now, when I was excited when I saw that you're an expert in trauma, what led you to that area of expertise?
Yeah, it's a great question. I've got kids in college and college-age children, and I think often in your life, when you're young, you think that you're going to take quite a linear course, right? You're going to set a goal and you're going to pursue it. It will be a relatively straight line, and you'll land where you plan to land. I had never really planned to be an expert in trauma or cognitive impairment or any of those things necessarily. I came to Vanderbilt to do a psychology residency. This was almost 25 years ago. And at the time, there was a professor, now a colleague, but then my boss, about to be my boss. And he was starting a research program focused on mental health outcomes after intensive care. And he needed a psychologist. And I was the only one around. It was really that simple, right? I was a warm body. And I hadn't planned to be a researcher, far from it. We had a baby on the way and we enjoyed Nashville. And back in those days, you could hire people a little more easily. You didn't have to have a contract. You could just have a handshake. And he said one day, would you like to be a psychologist on the team? Would you like a job? And I said, I need a job. And he said, well, how much psychologists make? And I told him some number. I think now it was pretty low, but I told him a number. He said, that's fine. And then a couple weeks later, I started working in this field at the intersection of medicine and mental health, if you will. And I didn't know what I would find really with respect to trauma. And I think in some ways, the trauma kind of found me, as I was engaging patients and hearing their stories. I had done some work with veterans, quite a bit of work with veterans. So I understood trauma in a combat arena. But as I interacted with ICU survivors, I started quickly to understand that they themselves had their own challenges with trauma. It didn't involve IED explosions, it didn't involve bullets, but it was trauma nonetheless. It was the experience of being fine on a Thursday and being in the ICU on life support on a Friday. It was the experience of having a prolonged critical illness as a young man or woman, being worried that you wouldn't see your unborn baby or ever return to your family. It was the trauma of vivid and visceral delusions in the context of delirium. As I got to know our patients, I'd go to their homes and evaluate them. I heard these stories and I began to realize what a profound public health problem and what a deeply personal problem this was, medical trauma. And that's really what set me down this path.
Thank you. And before we continue, can you give us some context or a definition of what is medical trauma?
Yeah, it's a really good question. And I don't know that there is a simple, pithy definition, but in general, I think it's the emotional distress, sometimes physiological too, but it's the emotional distress that is born out of medical experiences and medical encounters. Sometimes the encounters are surgeries, sometimes the encounters are being in the ICU, sometimes the encounters are receiving an unwanted diagnosis that is terrifying, being diagnosed with cancer or perhaps a chronic illness. Sometimes the trauma isn't about an illness at all. Sometimes the trauma is the experience of gaslighting, right? Interacting with a physician that you trust and feeling like they're minimizing you in some way that is profound or perhaps dramatic. And sometimes the trauma inflicts not only the patient, but sometimes it's the family member. When we have studied this and when others have studied it, they have found two things. One, they have found that medical trauma in many populations, survivors of a cardiac arrest, survivors of critical illness, to name just two, they found that rates of PTSD in those populations are very comparable to what we would see in Vietnam combat veterans, let's say, if we want to use a common population where we talk about PTSD. And they have found that often rates of PTSD in family members of patients are every bit as high as they are in patients, sometimes even worse. So I think one insight that I have developed, not hugely difficult to arrive at, it seems fairly obvious, is that in a medical context, trauma is not just an individual patient problem. Trauma is a family problem, right? It doesn't just impact patient, it impacts a son, a daughter, a mother, father, a friend, a neighbor, a cousin, whoever the caregiver would be, perhaps, whoever's in their sphere of influence, that trauma can affect them as well. And I think we fail to realize that far too often. This is a family problem.
Thank you so much. I'm happy that we're having this conversation because I've had surgeries and I called it medical trauma because of the after effect, the PTSD that I experience after. And I like that you said that it's not just the patient, it's also the caregivers and the family members, because I remember during my cancer journey that I shared with someone that cancer is not just the individual, it's an entire family that is affected. So here is an expert putting context into my individual theory that I created.
Yeah, well, I appreciate you saying that. I hope you're doing well, and I agree with that. And I think the other thing that's important, I work in an academic environment, and in academic environments, there can be a little bit, as you know, a little bit of an ivory tower, right? Where we're trying to be very precise, and sometimes we are living in our own world, if you will, removed from a lot of realities. And in this academic ivory tower, sometimes people spend a lot of time debating whether something is trauma or whether it's not. And to me, that's a little bit like, the theologians of old who were debating how many angels could fit on the head of a pin, right? If you remember that reference. Who knows what the answer is to that? But more importantly, I think that's not really helpful. That's not a helpful question. And equally, I think some people are a little too fixated on, is this trauma? Is it not? If you are identifying it as trauma for you, who am I to tell you that it's not traumatic, right? Like, my challenge and my opportunity as a healthcare provider, I think, is to meet you where you are, try to support you and assist you in this process of grieving and acceptance and transforming and all the things we try to do, instead of saying to you, oh, by the way, that really is not very traumatic, right? And I think far too often in healthcare, we're gatekeeping people and telling people what actually is and isn't traumatic. And I think those efforts are A, misplaced, and B, I think they're really harmful.
You brought up the whole issue of the family trauma, and my guesstimate is that family trauma is less often diagnosed than the patient trauma, even if it numbers, and it's probably occurring in more numbers because most people have more than one other person in their family. So
Right. Yeah, I would agree. Mitzi, I would agree with that. And I would say the following: if we take intensive care, let's forget for a minute the huge number of cases of cardiac arrest and cancer and MS and HIV/AIDS. I go down the list. But let's just take intensive care as an example. If we look at intensive care, what we know is that in North America, these are rough estimates, but they're pretty accurate. In North America, there are about 6 million people admitted to the medical intensive care unit annually, every year, about 6 million. And of that number, about 15 to 20% die in the ICU. So now we're down to about 4.8 million. And then another few 100,000 die in the next 3 to 6 months or so. They never really recovered. They made it out of the ICU, they die. So a year after the ICU, let's say, we've got somewhere in the neighborhood in North America of 4 million plus people who are surviving, who experienced a bona fide critical illness. By that, I mean, they weren't in the ICU for 14 hours. They were truly critically ill. And if you look at the literature, if you look really conservatively, very conservatively, the literature would tell us that at least 12 to 15% of those people, more likely 20, have significant symptoms of PTSD, let alone anxiety or depression. So if we took a really low number, 10%, that's 400,000 people a year, right, in North America that are traumatized by the effects of critical illness. And then if we assume, Mitzi, that every one of those people has, again, I'm going to make a number up, 1.5 family members, or 1.8 or whatever, we're talking about a gigantic number, right? It's a huge number. And the problem is, often healthcare providers, that they're busy, they're well-meaning, they're outmatched, they've got too much to do with too little time, all of that. So often healthcare providers are not alerting them to the very real possibility that they are looking at a season of dealing with the effects of trauma. And they're having problems sleeping. They may have a lot of conflict in their relationships. They may be quite emotional. They may be very reactive if they're watching a TV show involving a hospital setting. these are family members or patients, they may be having panic attacks as they're driving back to the hospital where they went to the ER before they were admitted to the ICU. All these things are happening. And if we can put them in context, right, if we can say, hey, this is actually kind of normal for people with PTSD, this has a name, right, and you're not going crazy, we're going to name it, we're going to tell you what to expect, there's a path forward through treatment, here's what it is. If we do that, people often do quite well, but often we don't do that. And people have no idea what's happening. They think they're losing their mind. And I think it's a real tragedy because I think to a certain extent, some of this suffering is a little bit needless.
Wow.
So, I mean, you just mentioned that's just the ICU, right? But like I sit there and I think, for example, when my husband went through a period from 2012 to 2018 where he had cancer 3 times, parathyroid surgeries, he got an E. coli infection, like he had all kinds of major medical health issues that basically had him completely out of commission for that period of time. But he was never out of ICU. But I could assure you there was a lot of medical trauma for him and certainly for the rest of the family in dealing with all of that.
Yeah, I think that's right. And I reference the ICU just because I happen to have a clinic where I treat ICU survivors. I see patients in the ICU. But yes, we could apply this same yardstick if we wanted to people like your husband or to so many others where they're having these challenges. And often the thing that makes these challenges the hardest, not always, but often the thing that makes it the hardest is when they're unexpected, right? Like if you can say to someone, you're going to get a scan. If we find out it's cancer, here's the game plan. That's still actually terrifying, right? That's terrifying. But when it is problems that pop up out of nowhere, followed by another and another and another and another, it's really difficult for people. And I think the problem is what happens in the context of multiple medical events is the first one knocks you down. You start getting back up, but you don't make it all the way back. The second one knocks you down, right? This happens repeatedly. And after your 5th or 6th insult, you've gone a long way down the hill, right? And I think the example I would give, when our kids were little, I don't know that they would want to do this with me now, but when they were little, they did. We would go to Chuck E. Cheese, if you've been there, and they'd play in the ball pit, and all of that. And we would play that game whack-a-mole, which I really loved. If you remember, you've got a club with some felt over it, and you've got these little gophers, and they pop their heads up, you knock one down, and another one pops up. And there are a lot of patients where I would say that is their health journey. Like you knock one problem down, and as soon as you do, another one pops up. This is the experience, I think, of hundreds of thousands, if not millions of people for various reasons. And this is where we often see such profound anxiety and depression and PTSD, where the one problem is knocked down and then the other one shows up and they just keep showing up in succession.
As you're speaking, Dr. Jackson, because I've had multiple visits to the ER and quite a number of surgeries. But one of the things that I have never received is psychological support.
Right. Yeah.
Right. That's not available for patients of medical trauma.
Right. It's not.
Yeah. And oftentimes you mentioned that people will leave the hospital and they're not at the level that they entered when they were admitted.
Yeah.
And many are unaware that they're dealing with PTSD and medical trauma.
Yeah, they are. Many people are unaware, and it's quite, I don't want to overstate or be too dramatic, but I think this is true. It's a stain to me, honestly, on the healthcare system, with respect, that we don't do a better job addressing these mental health issues in the moment, because if they're left unaddressed, they create other problems. And the vicious cycle we see very often. This has been well described by people like Don Edmondson at Columbia in the context of medical PTSD. So often what we see is that people have cardiac problems, let's say, and they develop PTSD after that pretty reliably. They develop PTSD. And then because they are anxious and hypervigilant and generally activated by anything that reminds them of the trauma, the cardiac arrest or whatever it might be, they often are not very compliant. So there's been research that says they don't want to take their heart meds because taking them reminds them of the heart attack they had. There's been research that has said they're reluctant to go to the ER when they have chest pain because they think that if they do, they'll get readmitted, they'll wind up on a respirator. That's the last thing they want. It was so traumatic. They would rather take their chances and sit it out, right? So they don't go to the ER. So as you can imagine, what happens is, step one, you develop PTSD after a cardiac arrest. Step two, you neglect your health because of all of the stress that you're under. Step three, you're more likely then to have a new cardiac event. Step four, that's going to worsen your PTSD, right? So it's just a vicious cycle, and one builds on the other. And I think this isn't original, obviously, with me. Other people have said it more eloquently, but I think we need to continue to stop thinking of medical health and mental health as two separate things. I mean, I think we need to begin to integrate them and understand, if you poke me, I'm going to bleed. Like if you have major surgery, if you have a chronic illness, if you have a life-threatening illness, et cetera, that is not just affecting your heart or your kidneys or your femur or whatever it is. Very often it's affecting your mental health at a very deep level. And the tragedy of not informing people about that help is available very often, and often it's quite effective. But the key is it's only effective if you get it, right? If you get it. If you don't get it, it's not effective. And if people are not aware of what's going on, they're not going to pursue that help. So that's the needless tragedy to me of this.
What types of help are available for people who are going through this medical trauma, or for family members who recognize it in someone? Like, could you talk a little bit about what kind of resources are out there and how somebody would go about finding them? Because everybody lives in different areas. So
They do. Yeah, it's really interesting. When I started to write a book about medical trauma, following my first book, and my book will come out in February, and I'd love to come back on it. If you'd indulge me, I'd love to come back on and talk about it. So, when you start writing a book, one thing you think about when you have the idea is you think, I've got to see if somebody else has written this book, because if they have, obviously I'm not going to write it. And so honestly, I'm pretty dialed into this topic, of course, but I thought, man, this is important enough. Surely someone has written something for patients about medical trauma. So, this is maybe a little bit of a me too, like I'm coming after somebody else. Somebody else has written this. So I looked and looked and looked and looked and looked, and I can say with full confidence, nobody else has written this, right? No one else has. Now, how that's happened, I don't know, but they haven't. And I think it reflects the general lack of awareness that we have about this problem. So I'm excited that this book will be one resource. With regard to treatment, what we know is that if you have anxiety or depression, or we could focus on PTSD, let's take PTSD as an example. If you get the right treatment for PTSD, and that could be EMDR, that could be exposure therapy, it could be cognitive processing therapy. It shouldn't be psychoanalytic psychotherapy. Like, it shouldn't be laying on a couch talking about your dreams about your mom. Like, that's not going to solve your PTSD. And it also shouldn't be just talking to your therapist about the weather, right? That's also not going to help it. But there are validated, empirically effective approaches to be used for PTSD. And if you use them, you're going to get better. And we think there may be unique approaches that are better or worse for medical trauma. We haven't evolved necessarily to the point that we know the answer to that question yet, but generally we know what works for PTSD. Equally, we know what works for anxiety or depression. Medication sometimes can be hugely helpful. So when we connect people to validated therapies, in my experience, they generally get better. But to your point, Mitzi, often people don't know necessarily the distinction between a psychologist and a social worker, let's say, or the distinction between a psychiatrist and a psychologist. They may not have no idea of what treatment they should ask for with regard to PTSD. So if they're getting the wrong treatment, 50 sessions in, they're not making any improvement, they may not know that. So I think we need to do a better job educating.
Thank you so much, Dr. Jackson. It has been a pleasure.
My pleasure.
And we would like to see you again very soon.
Okay, very good. Take care, friends.
Okay.
Thank you so much.
Bye-bye.
Have a wonderful week. Thank you.
If today's episode sparked something in you, don't let it end here. Change starts with action. Hit subscribe and join our community of life chasers.
We want to hear from you. While we don't have social media, you can connect with us through our personal YouTube channels.
Share your biggest takeaway and let us know how you're transforming your life. Remember, your next level life begins the moment you decide to claim it. Until next time, keep transforming.